This UCSD TV program is a presentation of University of California Television for educational and non-commercial use only.
Hi, everybody. I'm Dr. David Granite, and welcome to Health Matters. Medicine's changing, and it's changing in ways that not everyone is comfortable with or even understands. There are some things that maybe shouldn't change, and the model of the old-fashioned doctor that knew you and your family and knew what your house looked like, knew your grandmother, knew your kids, well, maybe that's the model we're going to come back to. Maybe that was the best way to deliver care. To help us through this, we have an expert, Dr. Rusty Kallenberg, who is Chief of the Division of Family Medicine at UCSD. Welcome.
Thank you.
Thank you for being here with us. When I think of family medicine, I sort of think of, I don't know, Marcus Welby. I think of the guy who knew your family from top to bottom. Is that fair? Is that a fair assessment?
I think that's a very fair assessment. There's some old wine that no matter what the bottle changes to is still good old wine. And I think that that's a very fair symbol of what family medicine is. My father was a GP in Cincinnati, and I grew up, fielding phone calls at home for him and watching him disappear on weekends to go make house calls. And I think that's a model that still exists today. It's become a little bit rarer to find, but it still exists.
Well, and it's funny that the general practitioner, in our current parlance, we would say was probably undertrained.
I think as medicine advanced, I think there's no question about that. I mean, he was a GP, and he was always interested in taking more courses and things like that, but there's no question that as we got into the end of the 60s and the beginning of the 70s, we realized that medicine had advanced a lot since World War II, developed a million specialties, lots of new knowledge, and the GP now needed to be more trained. And so in '69, we developed the Board of Family Medicine and 3-year training programs. And some people debate today about whether the training should actually be 4 years as opposed to 3.
Yeah, I mean, it seems like medical school shouldn't just be 4 years, given the amount of explosion in knowledge over the years. There are people out there who are going to think, well, what is my internist? Isn't that a family doc? Mm-hmm. What's the difference between an internist, pediatrician, and a family practitioner?
Right, I think, and those are good, that's a very good question, and there's a lot of overlap. And I guess I would say that the family physician takes care of people no matter what age. So a family physician would take care of newborn babies and infants and children, adolescents, and all the way through adulthood, and also into geriatric years, 70s, 80s, 90s, 100 plus. The general internist does the same kind of function in terms of total comprehensive care, but does it confined usually from adolescence to older age. And the pediatrician usually defines adolescence south. And so we do have a lot of overlap in the sense of being interested in the whole family, the context of the patient, their cultural and family background, the full breadth of things that they have as concerns, both biomedical as well as behavioral, but we just deal with different age groups. And the other thing that a lot of family medicine physicians do, not all, but they do obstetrics as well, so they're concerned with you even when you aren't here yet.
As you come into it. Now, I'm a pediatric eye specialist, and I know that my patients, as they get older and they start saying, can we still see you? And I go, well, you're 33, it's probably time to move on. There's that moment where you've had this long relationship, and then you're handing off, that's a little bit awkward. You don't have to worry about that handoff. Absolutely
not, and most of the kids are worried about it because they look kind of funny in the waiting room. That's their major driver when they're an adolescent to go to an adult doc. And I think that one of the things that's most powerful about family medicine is the family context. A pediatrician, and this is nothing to take away from them, they're very great advocates of their patients, their pediatric patients, with the patients' families. But when there's a problem that sort of has components that are the parent's component as well as the child's component, they sort of stop short of the parent's component, except when they're telling them not to smoke. But in a family medicine practice, you are really able to deal with all members of the family. And sometimes it's not infrequent that we have more than one family member in the exam room at a time. Always true in pediatrics,
Sure.
but a little less true in adult medicine. And that's very nice. It's very nice because the family context is palpable, it's visible.
Give us an insight into the mind of a doctor for a second. It's a little schizophrenic to go from seeing a baby to someone who's a geriatric age group, back to a 40-year-old sandwich mom who's being compressed on either side. How do you go from room to room, switch gears, and maintain your knowledge base to be able to do that?
Well, it's very interesting because this is a question that medical students bring up all the time. And sometimes it's a little frustrating the way they bring it up, because on the one hand they say, well, what is the intellectual challenge of family medicine? And then 4 minutes later in the conversation, they say, how could you possibly keep up? So I sort of say, well, okay, that's the intellectual challenge. And most physicians, the other thing I say to them is most physicians practice epidemiologically, and long word, but what that basically means is we know what we see, we know what we do every day. I would venture to say there's parts of ophthalmology that you wouldn't touch with a 10-foot probe.
Absolutely.
Because we've now divided the eye into the front, the back, and all kinds of different pieces. And so in family medicine, it's sort of the same thing. We are a jack of many trades, and we are a master of some, including what I would call comorbidity. So how do diseases interact with one another? How do you treat someone who's both depressed and diabetic? How do you treat someone who's having family problems and also has heart failure?
You sound like you've defined one of the problems in medical care today, is these silos that people end up with, where the endocrinologist is dealing with the diabetes and the patient says, well, I've just not been feeling well today. Well, you need to talk to somebody else about that. And there's who looks at the big picture and says, well, wait a second, that medicine you're taking may be impacting you from a psychological standpoint, and the idea of injecting yourself every day is bothering you, or your father died of diabetes and you're afraid you're going to die. Who's looking at that big picture?
Well, it's us, and there aren't enough of us. And I think that's really a really critical point that I was getting at, the comorbidity. I just saw a young man in the practice yesterday, and he has a very interesting set of 2 neurologic problems. And he had seen a neurosurgeon, a neurologist or 2. He'd seen a cardiologist, he'd seen a hematologist, and he came to see me so we could just sort of chat about everything and put it all together. And so I often think of the physicians on Star Trek. If you look at Bones and
Yes.
all of his successors, they're all generalists. They're all primary care physicians, even though they have the world's best tools, some of which I would love to have. And they're dealing with things that are way over anyone's head because it's on television. But they are all generalists, and they're generalists in the sense that they know how to approach a patient, they know how to approach the patient's family, their context, where they're coming from, community-wise, environmentally-wise, and can put all things in context. So I think that I get lots of people coming to me telling me, what do you think of this story? Talking about their relative or their friend or themselves. And frequently my first response, is, well, do you have a primary care physician? Because a lot of the problems seem to be from that disjointed healthcare system that they're trying to navigate. So as complex as we get and as more technologically advanced as we get, we're still going to need primary care physicians to help understand what part of the technology is appropriate to use and how can we help the patient understand that and decide with them what to use.
There's no computer that matches the pattern recognition of the human brain. And I know in my office, I feel like sometimes a crime scene investigator where I'm getting clues and I need to send those clues back to the primary care physician to say, okay, you've gotten the clues from me, you got the clues from the neurologist, you got the clues from the endocrinologist. Who's going to see the big picture? And the big picture person is here.
Absolutely.
You said
it's fun.
Yeah, you said you talked about medical students. Who goes into primary care? I mean, honestly, it's not the highest reimbursed part of medicine.
We're improving, but everybody else is still accelerating too.
Yeah, and the irony is that when somebody comes to see you, for those 15 minutes, you're about the most important person in the world. They're hanging on every word. You're making a huge difference in their life. Goldman Sachs employees are getting $600,000 bonuses because you have to pay the best and brightest if you're going to get them to stay in investments. But How do we get the best and brightest to go into primary care?
Well, it is embarrassing to talk about salaries and things like that in physicians. I mean, if we're in a group of physicians, we can always talk about it and we can complain and kick each other and all that stuff.
It's all relative, but
absolutely.
That's why I mentioned the Goldman Sachs people, because they dwarf what we're talking about.
Absolutely. So I guess what I would say is that primary care salaries have actually improved a substantial amount in the last 3 or 4 years. One of the statistics I was just reading was about from $145,000 to $178,000 a year. So those are not salaries to sneeze at. I think that the magic though is that you've got to start with the right substrate to be a family doc. I tell medical students that let me preface this by saying that when I'm visiting with a surgeon and I'm unconscious and he's about to do something to me or she, that's a pretty important 15 minutes also. So I really give credit where credit is due. I've had the benefits of high-tech specialists working on me, and I'm glad they're there. So that said, this is not an either-or, this is an and proposition. And so when I talk to medical students, I say, if the last thing that you go to sleep thinking about at night is a specific patient with a name and a face, as opposed to an ology or a procedure or a technical thing, then you might be a primary care physician. If you're good at talking to people and listening to people and wanting to be involved with people over time, you might be a primary care physician. Okay? And the way we try and assess that when people apply to school is we ask them what they've done. If they've worked in a rat tail lab, in the NIH,
Yes.
dissecting parts of, rat anatomy, it's a little bit of a stretch for them to tell me that they might be interested in family medicine. If they've worked in a nursing home, if they've tutored children, if they've worked in Vista or AmeriCorps, if they're alternate profession choices, and we ask them things like that. If you couldn't be in medicine, what would you be? If they want to be an electrical engineer, they might not be, a family physician. It's not to say that we don't deal with a lot of technical things. We do office surgery, we do all kinds of things in family medicine, but our love is to interact with patients. So I tell my wife, well, the medicine was not thrilling today, but boy, I met fascinating people all day long.
I come home and I tell my wife's story. I'm not a family medicine doctor, but I come home and I tell my wife story. She goes, boy, my doctors don't talk to me. How do you know this?
That's right.
And some days I think I should have been, family, but I have long-term relationships with my patients over long time. Ophthalmology is blessed that way.
That's right.
I went to Yale for medical school, and there used to be this joke line, Yale doesn't train primary care doctors. And there's this sort of hierarchy within medicine that, the neurosurgeon and the hard-charging person and all that. Is that perspective still in medical schools today, where primary care isn't considered the hot, sexy field?
I think that that's true. I think it varies sort of societally and with time periods. So, but I think among sort of a group of specialists and high-tech physicians, I think that there still is some of that prejudice. I point out there are a few schools that sort of believe that they're above training family physicians, and Yale might be one of them. But,
it was. I don't know if it is.
I don't know if it is today either. But there are schools like the University of Washington, which I point out quite frequently, is one of the top NIH grant getters in the country, and is an outstanding producer of primary care physicians and responsible for several states in the Northwest that don't have medical schools and producing family physicians for that group of states. And so I think this is an and proposition. Again, I think with medical students, there is a little bit of that hierarchy, but again, it depends upon whether or not they're the right substrate that wants to go into family medicine. I will say that although the numbers of students selecting family medicine has declined over the last few years, and we're trying to start some ways to improve that again. This is a pendulum we've seen go back and forth a few times, and I think we're actually moving back in the right direction. The ones who have chosen family medicine, at least at UCSD, have been outstanding. I mean, they're getting awards on graduation day. And so we don't see poor quality people, going into family medicine.
Couldn't imagine that they could do it.
And I think that that's probably correct. And so I'm pretty positive when I see who's going into family medicine. We just need to see more of them.
So you've convinced me. I think this is a very clear issue of the role and the importance. But in this day and age that we live in, there's the other issues the cost of care, the quality of care, keeping people out of the hospital, delivery care. What's your vision for the role that family medicine plays and how it can improve our healthcare system by running people through the family medicine model?
I think I think it's a key. I mean, I think primary care is a key, and there's a lot of data that's been amassed about this topic. There are people who debate this and who think that specialists do it better and all that kind of stuff, but I have to say that in looking at the data, reading over the data, it's fairly overwhelming. It comes from multiple countries, multiple decades, multiple ways of looking at it, and countries that have actually experimented with this in real time by improving their primary care, squads and getting better outcomes in their patient populations.
Well, one of the things that hit me while I was preparing for this is that the greatest advances in medicine were things like hand washing. And family practice gets at that rather than treating the person at the end who's got a tumor somewhere and spending gazillions of dollars there. Stopping them from smoking on the front end because their family doctor intervened has got to be more cost effective.
Right. I think that's true, encouraging them to do proper self-care, to do proper exercise, diet, nutrition, things like that. And also just coordinating the care at the earlier levels so that they do get the best care, get the appropriate guidelines-driven, evidence-based care, and so that patients are not neglected to the point where they need, really sort of extreme interventions. Now, we're always going to need extreme intervention people because bad stuff happens sometimes, even if you've led a healthy life. People get hit by trucks, all kinds of things.
Of course.
And so we're going to need that stuff. But I think that much of medical care would be better organized, more cost-effectively delivered if everyone had what we now call, the new buzzword, is a patient-centered medical home. And that's a little bit of the old wine in new bottles.
Right. The Marcus Welby GP that knew who you were.
It's the old wine that consists of some very now clearly enunciated components. So one is access. You've got to be able to get to your physician when you need to and not be told that the next appointment's in 12 weeks or, call back.
You and I were talking before the show, and you said a lot of the care you provide happens between appointments.
Absolutely.
And you talked about that old-fashioned device called the telephone.
Yes, right. Very useful still, even in our years of our current situation of twittering and doing all kinds of stuff like that. Sometimes a real-time two-way conversation is very important, especially if you know the patient, you know their voice, you know when you can detect emotion in that voice, and you can really interact with that patient. So the phone is certainly a great access tool, as is the internet. So we now have something called My Chart in our medical record. Kaiser has it, other people have it, and it allows me to interact with my patients asynchronously, when I've got time and they've got time, cuts down telephone tag and all kinds of other inefficiencies.
This is part of an electronic medical record?
Correct. It's part of our electronic medical record, and it's a portal of access that is additive to the phone and seeing the patients face-to-face.
So the patient can access their own medical record, ask you a question, and communicate back and forth?
Absolutely. And we can decide whether, knowing the patient, we don't do this with people we've never seen before. That's a whole other little game in town, which I don't find very attractive. These are people we've seen. We know, we've laid eyes on, we've laid a glove on, and we know who they are, and they know who we are. And so when we interact with them, we have the full sort of contextual knowledge of who they are. And so in that situation, we can sometimes say, gee, I don't really think we need to see you. I think you need to do X, Y, and Z, and email me back in 2 days, and let me know how you're doing.
And you know they will because you know your patient.
That's right, and because they love this kind of access.
And if it's somebody you don't trust to come back, you might say, get on in.
Absolutely. And you also don't spend a lot of time spending 30 minutes doing emails back and forth. I mean, at some point, you need to see the person face to face and, have a nice conversation with them.
What a great advantage, though, for them to be able to access you that way.
I think it's a tremendous advantage. They say everybody needs a good carpenter, a good electrician, a good auto mechanic. I think you need a good primary care physician, and you need to be able to get to them. Yes, right, and you need to be able to get to them. And so access is a critical thing. Another critical thing is continuity, and we've talked about this a little bit. Knowing someone over time gives you a tremendous advantage in taking care of them, in knowing when to wait, when to watch, or when to use the power of the pen and spend part of our $2.2 trillion of healthcare.
Right.
So I think you can only do that in the context of knowing the patient over time.
John walks in and you go, did you lose weight?
Exactly. You look down.
Right.
You look pale.
Right.
All kinds of things. And so continuity is critical. The other two components, or three components, one is comprehensiveness, and the other one is coordination, and then the other is community context. So just to say a word about each of those real quick, comprehensiveness means that in family medicine, you can get probably 85 to 95% of your needs taken care of by us. Now, that may not be a single us. Sometimes it is when you're in a small town and there's a single us who does OB and does all kinds of things.
Sure.
In an urban area, we practice in gangs, teams, and in each one of our family medicine offices at UCSD, you can get a vasectomy if you're interested in not having children.
No, thank you right now.
Follow your pregnancy if you're interested in having children. You can get a C-section, not actually in the office, but you can, one of our docs will do it for you if you need a C-section. You can have your shoulder injected if you have a sports medicine injury. You can talk to a pharmacist if you need real advice about how to get the best out of Part D Medicare. You can see a collaborative care counselor if you have a mental health problem or a behavioral health problem or you're depressed, all in our office. And this is called the patient-centered medical home.
Absolutely. Now, there's a phrase that comes up that I hear all the time, the gatekeeper, which sounds like you are restricting access to everybody else. But flipping that perspective and saying, not a gatekeeper, this is, we're the people that this is your house, you know, and this is where we want you to be.
Right.
And yeah, that gate's there, and we can open it when we know which gates for you to go to,
Exactly.
rather than we're preventing you from keeping.
This was a tough historical event that occurred, and it gives great insight into proper PR, and it also gives great insight into the American people, and I think one of the conundrums that they face, one of the challenges that they face. As managed care grew up in the 90s, the concept was comprehensive care and coordination of care. We prefer to call this care coordination. The point was that you could actually have someone to discuss your healthcare needs and mutually shared decision-making wise decide what's best for you.
Right.
And what happened though was that the greedier folks in managed care decided to make this financially maximally beneficial to themselves, and that was done by restricting care. And some care is appropriate to restrict because it's really unnecessary. So some people estimate that we spend 30% of our $2.2 trillion every year that doesn't really give anyone any value.
So it's not really restricting care, it's practicing good medicine.
It's practicing good medicine, it's practicing good husbandry of limited resources in society, and it's not abandoning the advocacy for your patient. So it's not like we ever say, we should do this for you, but there isn't enough money. That's not what we're doing.
Right.
We're saying, I don't think you need to do this because I think we can watch this for a minute, or we can do it with this lower tech approach. And if that doesn't work, if that doesn't answer the problem, or if it gets worse, then we'll take care of it. And we're pretty skilled at not losing somebody by doing that waiting.
Sure, and the risk-benefit ratio of some procedures doesn't weigh out right.
Yeah, I mean, this is the other thing. It's the fishing rod in the lake coming up with a boot phenomenon. So I have patients who come to me and say, hey, I got this body scan. I've been scanned from one end to the other, and I got all these, and what do all these things mean, and what do I need? And you're facing things that we can detect nowadays, because we can detect a lot of stuff. When we first developed MRIs, we were seeing all kinds of stuff we didn't know was there, but in order to follow up a lot of those things, sometimes you have to take out sharp objects and sort of go after things, and that always has pluses and minuses. So there's a very strict and well-developed science about what is a good thing to do and what is a bad thing to do and how to assess that, and that's what we have to apply when we're trying to, dole out all the medical industrial complex goods that we have.
Sure, and it's a fault of a specialist, speaking as one, where we think about I think about the eyes, and so stepping back and having your perspective is a very important issue for families.
And the other thing that I think that the specialists find themselves in is that if the patient gets referred to a specialist, they know that the primary care physician wants to be reassured that there's nothing wrong with that part of their patient. And so there is a tremendous pressure on you guys to sort of really rule everything out.
Right.
And
yes, there is.
And I respect that. And so that's why I don't send people to you unless I have a formulated question and I can give some guidance into what I really would like ruled out and what the question really is for you to solve. And that's why I think a lot of the power of the pen really does rest with the primary care physician, because me and the patient, we decide, well, what do you want to do about this? Do you want to go see the surgeon? Well, I don't think I'd have surgery anyway. Well, then I say, well, okay, then let's just keep talking ourselves, and if you think you might want surgery, then it's time to go see the surgeon. So I think if you explain that to patients and talk with them and share things with them, then you're on the same page. You're not seen as an enemy restricting them from stuff.
You have a trust built up over many years that they know you're on their side.
And I'll tell you, patient education makes a big difference in this. A mere 10 years ago, you'd see somebody come in with sinusitis, and you'd get your arm wrestling gear on because you'd know that they want an antibiotic.
Yeah.
And you could either say, oh, okay, here's the antibiotic, goodbye, and I'll see the next patient. Or you could spend 10 minutes and explain to them why an antibiotic was not a good thing, might even be a bad thing, and you'd convince probably 85% of the people. There'd be 15% that would demand the amoxicillin. We went on public television, and the infectious disease experts went on public television and on the radio and made advertisements and explained to people that this is dangerous for you and that the more we use our antibiotics, the less effective they are. Now, if I start that rap with a patient because I'm ready for a fight, the patient says, I don't want antibiotics. I don't need antibiotics. Don't give them to me unless I really need them. So the public is educable about these things, and it's our failing if we don't educate them.
Well, that leads me in the last few minutes to ask you what one of the things I've been waiting to ask you. There's a healthcare debate that's going on in Washington, D.C. What, if the world according to you, you have your crystal ball, what would you like to see us morph into, not from a political standpoint, but from really the best way to deliver healthcare in recognizing the restrictions that we have in the real world and the role family medicine plays in that, the future according to you?
Well, this is a little bit on my soapbox. You gave it to me,
so I'll get on it. We don't have much time, but we're giving it to you.
So I think that everyone needs a primary care physician. And it could be a general internist, it could be a pediatrician, it can be a family physician. I think it should be a family physician, but that's me. And I think if everybody had a family physician, I think we would be much better at husbanding our resources. If we save 30% of $2.2 trillion, we would have enough money to pay for everybody. We would have enough money to repair Medicare. We would have enough money to pay for all the uninsured. And so I think that that's a key critical point. And it means growing more primary care physicians, more family physicians, and investing in the parts of the system that would really support a patient-centered medical home. I think the other things that we need to do is we really do need to have the evidence brought to bear when we make medical decisions. We need to have everybody covered. We need to have no pre-existing conditions, none of those games. I really have yet to see what an insurance company actually adds to the equation of delivering care. I used to watch my father deliver care. Patients would roll off $1 from their pocket and give it to him. He was happy. And I have since concluded that there's enough going on in the interaction between the doctor and the patient for neither of us to be worried about money at the time of the transaction. So we need to extricate our care delivery from the money situation. And the more that it's prepaid, the more that it's bundled, the more that it's capitated even, the more that it's taken away from the day-to-day interactions, then we can focus on quality, we can focus on doing the right thing every time, and the patients will be happier and better served, and we'll be happier doctors, and the country will be better spending its healthcare dollars.
Love it. Thank you. And thank you for taking your valuable time to be on the show.
It was a pleasure.
I know you were seeing patients all morning. You're probably going to go back to the office after this and do more work.
Finish all their notes.
Yeah, welcome to being a doctor, right? And that's what you do. But you love it. Your energy is palpable.
It's terrific. It's the best profession I've ever seen. When I have enough time to interact with patients and everything, there's nothing I would rather be doing.
That's what we want in medicine. I love it. Thank you again.
Thank you.
You've been listening to Dr. Kallenberg, who is an expert in family medicine and the delivery of care. What I hope you heard is the way you can have a partnership with your physician and be involved in your own health care. And actually your health care improves. It improves when you have somebody who knows you well, who can say, you don't look like yourself today, who's seen you over the years. That's really the old is new again concept that we talked about today. So think about that when you're talking about your own health care and how it gets delivered, and when you think about the entire healthcare debate that's going on right now as we speak. I'm Dr. David Granite, and as always, knowledge is power right here on Health Matters.